around the abdomen. I'm not sure about the other areas of the body, but at least for the abdomen, it has been proved to be that, right? Stress, right? Aging. As people get older, they are more likely to get high blood pressure. And the highest, as I said, 50% at the age of 50 years. Despite all these things you have to give up, ladies and gentlemen, and that is salt, alcohol, tobacco, all the good things in life, right? Hypertension is both preventable and treatable. Prevention and treatment of this condition, along with other cardiovascular risk factors, has brought about reduction in deaths from heart diseases in other countries. This is possible in Kenya as well. Ladies and gentlemen, the Ministry of Public Health and Sanitation and the Government of Kenya is committed to ensuring all Kenyans have access to highest attainable health care as outlined in the Constitution of 2010. As a ministry, we are going to continue executing our mandate of providing high quality preventive and promotive health services to all Kenyans. As we join the global community in marking this day, our clarion call is that we need to lead the way in creating awareness and encouraging our family members, friends, and colleagues to go for regular health checks, as this helps prevent high blood pressure. Thank you very much.
This session now, it's a question and answer session. Quite often when you have a session like this, there would be a pre-test and a post-test to just know whether there's been improvement or not. And this subject being discussed today actually amazes me quite a bit when we talk to people or visit the villages, because, for example, there are so many people in the village, when you go, if they have been diagnosed to have hypertension, after they are started on treatment, they will say that pressure imeisha. And you tell them, nilikuwa na kwa dawa lakini sasa hakuna haja, pressure imeisha. So the question we really need to ask, when do you stop treatment for hypertension? I think that's a very important message we need to drive today. Now, the other thing about foods, I think there's been issues of, we've been told about healthy diet, but what is the practice quite often? Today, the emphasis is on vegetables and fruits, but in this country, you'll find maybe over lunchtime, people go and roast meat, half a kilo. They'll only ask for a small portion of vegetables, like kienyeji. Then they'll ask kachumbari with a lot of salt to taste nice. And after that, they go to the office. They'll drink tea with a sausage, like the director saw me doing today and wondered. And then in the evening, before they go home, they pass somewhere again for the nyama choma. And when they go home for dinner, they say, you know, you must always eat in the house, otherwise the matrimonial issues will become a problem. So how much food is that? That is the practice. So what message are we driving, and how practical is it? And I think the other thing, and this the final one, is the issue of high normal. A lot of people in the middle class, once they go for a pressure check and it is 120/90, they always say, it is high normal. And they say normal means I'm still normal. But the truth of the matter is, that is the point you start living in denial. I think by this time, the reality is coming in. So there are a lot of issues, I think, about hypertension, and that's why it's a silent killer. And therefore, during this session, we want to invite questions and answers, and also comments. I know we have some of our specialists here today from the University of Nairobi. I can see Professor Ogola and others. Even if it is a comment, maybe for the next 6 or so minutes, if we can do that, questions, answers, or comments important for this topic, we welcome them.
We are told that cardiovascular diseases are costly in the healthcare system. I just want you to know if you have a figure of how much we've been spending on these diseases. And then if know the government has been effecting taxes on cigarettes. I just want to know if there has been an effect in terms of how, if the cases of high blood pressure have gone up or down due to the policies.
About the cost to the system, I don't think I really have figures. Probably you guys who work in the ministry might have figures. I want to sort of highlight three important things. One is to reiterate what my friend Dr. T there has said, is that as we create this awareness, we create a demand for services. And if we don't satisfy that demand, then you demoralize and you spoil the program. So that I think it is critically important for the ministry to ensure that the lower levels of the healthcare system are equipped, one, to diagnose blood pressure and sugar and all that, and two, that they are equipped to treat, not just with the presence of drugs, but also training of the healthcare givers. My final point is that we focused on adults in the presentations today, rightly so. Blood pressure rises as you age. But actually the origins of elevated blood pressure, like all cardiovascular risk factors, start very early in childhood. And therefore, in our focus on non-communicable diseases, we have to start early. We've got data now, one which has been presented in high school children, one which we are analyzing now in university students. And in a survey of high school children in Nairobi, if you corrected their blood pressure for their age and height, then we have a prevalence of hypertension of 20 to 30%. I mean, that is absolutely scary. And so issues like physical activity in schools, like diet in schools, like making sure that all the Coca-Cola kiosks next to our schools are dealt with, I think are important issues. I hope the Coca-Cola guys are not going to follow me. But those are very important issues to be addressed. I think I've talked too much, but I think those are critical issues to mention.
The cost of hypertension to the health system, actually, we're in the process of working out the cost to the health system. It is tremendous, direct and indirect cost, but there's somebody working on it. But it's a very complex thing because it's the cost will end up as calculating cost of a stroke, calculating cost of a heart attack, etc. So it's a very complex thing, but somebody is actually working on it. The other one is the effect of taxation on tobacco use. I don't think it is only taxation which has had the impact. It is the passing of the Tobacco Control Board, the Tobacco Control Act, which looks at the whole aspect of tobacco in terms of its sale, promotion, etc. We think that the prevalence is going to be down. There is a tobacco survey which is going to be conducted in youth, and it will give us an indication if what was happening, I think, about 3 years ago and now. So I think the Global Youth Tobacco Survey starts this year, and we'll get a comparison if it has actually reduced tobacco use in school children. So that gives you a comparison of a survey done 3 years ago and a survey which is being done now. And the other one is about how do we modify diet of our children attending school. We do have a program which is known as the School Health Program. We work with the Ministry of Education, and that is where we are trying to put in this issue of not the Coca-Cola kiosk, but the intake of salt and the junk foods. The junk foods would be classified, I think I would call chips as junk. My wife would call it once a month a delicacy for herself because she can't have it every. So what we are trying to do is tell the schools to teach children not to have this added salt. The issue is added salt to every food, right? One, chips are bad because they are fried with things which are unhealthy for for your health because it's fat. But what we are trying to do is also reduce salt intake by making sure that there is no added salt to food, right? So we are trying to say, limit your salt in food, right? But we are also saying the worst culprit is when you add salt, extra salt, which makes it worse, right? The other point taken is, yes, people are used to this thing called medicine and you are treated, right? When you tell them about healthy lifestyles, it's very difficult for us to conceptualize what difference. I mean, you're telling me to eat fruits, vegetables. I mean, this guy is not a doctor. He's a witch doctor, and he's practicing some form of traditional medicine. So it's very difficult for us to conceptualize it. But that's, I think, a fundamental issue, is that we have to make sure that our lifestyles do change. And the issue of availability of hypertensive drugs, we are actually, the new kit will have hypertensive drugs for health centers and dispensaries. And we are trying to limit it because the issue is, and limit the number of drugs so that lower level providers do not get confused. But the issue is, our own staff has an attitude problem in terms of, for them, they see somebody who has hypertension, prescribe drugs. And they don't go into details of making sure that they not only ask them to modify the diet, but the exercise, the smoking, the alcohol. Right? So everything goes together in a package. Because even if you are a hypertensive, you still have to take that package of healthy lifestyle. You cannot be hypertensive on drugs and yet continue smoking, continue taking high salt, continue drinking. It doesn't add any value. I probably think if you continue that, it probably may be having interactions with the drugs you are taking, because some of those hypertensive drugs says avoid alcohol. So the issue is you have to take the whole package of preventive measures, even if you are on drugs. The issue is if you are on drugs, it doesn't mean you start eating, putting on weight and become healthy. No, you still have to take that package. That package applies whether you are hypertensive, on drugs, or you are a normal person. Okay, thank you very much.